Welcome to the deep dive. Today, we're really getting into the heart of things, you could say.
Literally, we're looking at cardiovascular physiology, medical procedures, conditions, pulling from some pretty dense medical texts.
Yeah, the idea is to get some practical insights, right? How the heart, the whole circulatory system works, especially, when doctors need to step in.
Exactly. We've waded through a lot of material, cutting edge surgery, managing breathing, transplants, rhythm disorders.
Pacemakers, drugs, inflammation.
Right, monitoring with catheters, oxygen levels, muscle function, pulmonary hypertension. It's a long list.
Hypertrophic cardiomyopathy, surgical risks, valve issues, dosages, heart rate.
Dorsides, electrolytes, antiplatelets. It
Uh,
works.
Okay, quite a list.
Yeah.
But our goal here is to pull out the key stuff, the really interesting bits, and make it understandable. Give you that well-informed perspective.
Let's do it. Where should we start? Maybe something high-tech.
Sounds good. How about robotic heart surgery? Specifically, coronary artery revascularization.
Great starting point. It's really about moving towards less invasive approaches.
So not the big open chest surgery people usually picture.
Right. Instead of a full sternotomy cracking the chest open, they often use a much smaller cut on the left side. A minithoracotomy.
Like keyhole surgery, almost.
Sort of, yeah. A much smaller access point.
Sounds way better for recovery. But smaller space must mean different challenges, doesn't it?
Definitely. A key thing is the need for one lung ventilation pretty often.
One lung ventilation. So breathing with only half your lung capacity.
Essentially, yes. They need to collapse one lung to get the space and visibility to work on the heart.
Okay, that immediately brings up concerns, like getting enough oxygen.
That's the main one, potential for hypoxia, low oxygen levels. It's a risk both before they go on cardiopulmonary bypass, the heart-lung machine, and also after they come off. Constant monitoring is crucial.
So it's a trade-off. Less invasive access, but this tricky breathing management. You also mentioned it often avoids hypothermic cardiac arrest.
Yes, hypothermic cardiac arrest is when they cool the body way down and stop the heart completely to operate.
Which sounds pretty extreme.
It is, and it has its own risks, neurological issues, longer recovery.
Oh.
So being able to do robotic surgery often without stalking the heart, or at least without deep cooling, is a big plus for the right patients.
Makes sense. Okay, going back to that one lung breathing, how do they actually isolate just one lung?
They use a special breathing tube. It's called a double lumen tube.
Double lumen, so 2 channels.
Exactly. 2 separate passages within one tube. The anesthesiologist guides it down the trachea,
Okay.
and the tip sits just above the carina. That's the spot where the windpipe splits into the 2 main bronchi, one for each lung, like a fork in the road.
Got it, the main junction.
Then, using a bronchoscope, a little camera on a flexible tube, they carefully steer one of those lumens into either the right or left main bronchus.
So they can choose which lung gets the air.
Precisely. And the other lung can be allowed to collapse, giving the surgeon room to work.
What if they push that tube in too far? Seems like it could easily end up in the wrong spot.
That's a really good point. If it goes too deep, say into the right main bronchus, the camera might show what looks like another carina, a secondary carina.
A fake carina, how can they tell the difference?
It's all about the branching pattern you see. The real carina always shows 2 main paths splitting off left lung, right lung.
Okay.
But a secondary carina, being further down inside one lung, will show 2 branches, but both lead to different parts, different lobes within that same lung.
So if you're looking down the right pipe and see 2 branches splitting off, but neither goes left, that's the secondary one.
You got it. On the right, you'd see branches maybe to the upper lobe and then the middle lower lobes. On the left, branches to the upper and lower lobes. No path crossing over to the other lung means you're past the main junction.
Clever. Okay, so they've got the 2 placed, one lung is doing the work. What's the big physiological challenge now?
The main thing is messing up the balance between ventilation, getting air in, and perfusion blood flow. Veach-Kuch mismatch, we call it.
Right, because half the factory's offline, but the blood delivery system is still running.
Exactly. Blood flows through the non-ventilated lung, but it can't pick up oxygen there.
So how does the body handle that? Does it try to compensate?
It does. It has this neat trick called hypoxic pulmonary vasoconstriction, or HPV.
HPV, okay.
The blood vessels in the lung that isn't getting oxygen sense the low O2 levels and constrict. They tighten up.
And that does what?
It shunts blood away from that useless collapsed lung and sends it over to the working ventilated lung. It tries to optimize sending blood where the oxygen is.
That's pretty smart.
Yeah.
So what are the typical ventilator settings to help this process along?
Well, to maximize oxygen pickup in the working lung, they usually use very high oxygen concentration, often 100%. And they carefully control the breath size, the tidal volume, usually 6 to 8 mils per kilo of ideal body weight, and adjust the breathing rate to keep carbon dioxide levels in the normal range, like a PACO 2 around 35-40.
Right, high oxygen-controlled breaths. But what if, despite all that, the patient's oxygen levels still drop? Hypoxemia happens.
Then there's a kind of checklist. First thing always is recheck that tube position with the bronchoscope, make sure it hasn't slipped.
Makes sense. Tube first.
Then optimize hemodynamics, make sure blood pressure, cardiac output are stable so the oxygen that is picked up gets delivered effectively.
And if oxygen is still low after checking the tube and stabilizing circulation.
They might try applying CPAP, continuous positive airway pressure to the collapsed lung. Just a bit of pressure to keep the tiny air sacs, the alveoli, from totally collapsing might help a little.
Okay. Any other tricks?
Yeah, they could increase PEEP positive and expiratory pressure on the ventilated lung. That helps keep its air sacs open at the end of the breath, improving oxygen transfer.
CPAP on the down lung. Key P on the up lung.
Sort of, yeah. And in really tough situations, the surgeon might even have to temporarily clamp the pulmonary artery going to the non-ventilated lung.
Wow. Physically stop the blood flow to that side.
Yeah, it's a last resort sometimes, but forces all blood to the working lung. They might also try occasionally giving a few breaths of 100% oxygen to the collapsed lung just to kind of top it up.
Sounds like a constant balancing act. Now, I think I read somewhere that certain drugs can actually interfere with that helpful HPV response.
That's a really critical point. Yes, some drugs, like epoprostenol or inhaled nitric oxide, which are sometimes used for other lung or heart issues, can actually inhibit HPV.
So they stop the body from shunting blood away from the collapsed lung.
Exactly. They relax those blood vessels that we're trying to constrict. This makes the VTH mismatch worse and can drop oxygen levels further, so you have to be really careful using those during one lung ventilation.
Good to know. Okay, let's totally switch gears. Heart transplantation. What's physiologically unique about a transplanted heart?
The biggest thing, initially anyway, is that it's denervated.
Denervated, meaning the nerve connections are cut.
Right. During the transplant, the autonomic nerves, the ones that automatically control heart rate, contraction strength based on signals from the brain, those connections to the new heart are severed.
So it's kind of running on its own program. What does that mean for heart rate?
It means the heart's intrinsic pacemaker takes over completely, without the usual braking effect from the parasympathetic system. So the resting heart rate is usually faster, often around 100 to 110 beats per minute.
Starts out fast. But you mentioned sometimes they need pacemakers later.
Yeah, it's interesting. Over time, maybe 20-25% of recipients can develop bradycardia, a slow heart rate, sometimes slow enough to need a permanent pacemaker.
Huh. So if the heart rate does get too slow in a transplant patient, can doctors just give the standard drugs like atropine to speed it up?
That's the catch. Atropine works by blocking the parasympathetic nerves. But in a denervated heart...
Those nerves aren't connected anymore.
Exactly. So atropine won't work. It's like flipping a switch that isn't wired to anything.
So what does work if they need to increase the heart rate?
You need drugs that act directly on the heart muscle itself. Things like glucagon, isoproterenol, epinephrine, norepinephrine.
Direct stimulators.
Right. Isoproterenol is actually used quite commonly for this.
What about epinephrine and norepinephrine, adrenaline and noradrenaline? Do they act differently on a denervated heart?
They can have a more pronounced effect, potentially. Normally, your body has reflexes, like the baroreceptor reflex, that would slow the heart down if blood pressure shoots up from these drugs.
But those reflex nerves are cut too.
Precisely, so you lose that counterbalance. The heart rate boosting effect might be stronger, less opposed.
Okay. What about drugs that work both directly and indirectly, like ephedrine?
Ephedrine works partly by direct stimulation, but also by making nerve endings release norepinephrine. In a transplanted heart, that indirect part is much less effective because the nerve endings in the heart aren't functioning normally. So ephedrine's effect is often blunted or less predictable.
Interesting. So the direct action works, but the nerve release part doesn't contribute much. And if they do end up needing a pacemaker.
An implanted pacemaker works just fine. The leads go right into the heart muscle, delivering the electrical pulse directly. Bypasses the whole nerve issue.
Good to know. Okay, let's dive into rhythm problems. Wolff-Parkinson-White syndrome, WPW. What's the basic electrical issue there?
WPW is all about an extra electrical pathway. Normally, the signal goes from the atria, the top chambers, down to the ventricles, the bottom chambers, only through one point, the AV node, which controls the timing.
The gatekeeper.
Right. In WPW, there's a shortcut, an accessory pathway called the bundle of Kent that bypasses the AV node.
An extra wire, basically. What kind of trouble does that cause?
You'd think it would always cause chaos via that extra path, but funnily enough, the most common arrhythmia in WPW patients is actually AV nodal reentrant tachycardia, AVNRT.
Wait, the arrhythmia involves the normal AV node. How does that work?
Yeah, in about 95% of cases, the rapid heart rhythm is a reentrant circuit, a loop that uses the AV node for part of the journey, and some other pathway for the return trip. In WPW, the most common form of this, called orthodromic conduction.
Orthodromic.
The signal goes down the normal AV node pathway to the ventricles, and then zips back up to the atria via that accessory bundle of Kent pathway. Creates a fast loop.
Down the normal way, up the shortcut. And what does that look like on an ECG?
Typically, a narrow complex tachycardia. Because the ventricles are activated normally via the AV node, the QRS complex looks relatively normal, just fast. And for this type, standard drugs that slow down the AV node often work.
Okay, narrow complex AV node drugs are usually okay. But I remember reading WPW can sometimes cause a wide complex tachycardia, and that's much more dangerous.
You're absolutely right. Less common, maybe less than 10% of the time, the signal can travel the loop in the opposite direction. That's called antidromic conduction.
And I go.
So, backwards, essentially. The signal goes down the accessory pathway first, hitting the ventricles directly, and then travels back up through the AV node. Because the ventricles get activated abnormally via the shortcut.
The ECG looks wider.
Exactly. A wide, complex tachycardia. And this is much more unstable, potentially degenerating into things like ventricular fibrillation.
And this is where certain common heart drugs become dangerous.
Critically dangerous.
Yeah.
If you give drugs that block the AV node beta blockers, calcium channel blockers like verapamil or diltiazem, adenosine, digoxin, and someone having antidromic WPW tachycardia.
You block the normal upward escape route?
Forcing all the signals down that fast accessory pathway even faster, it can accelerate the ventricular rate dangerously, risking VFib. It's like closing the main highway exit during a traffic jam, forcing everyone onto a tiny side street.
Wow. Okay, absolutely crucial distinction. So for that specific situation, WPW with a wide complex tachycardia, what is the right drug?
The go-to intravenous drug is procainamide. It's an antiarrhythmic that slows conduction in the accessory pathway itself, potentially breaking the circuit.
Procainamide. Got it. And if drugs don't work?
Then electrical cardioversion, a controlled shock, is the next step.
Okay. Procainamide for wide complex WPW, avoid AV node blockers. Super important. Now, thinking about patients who already have pacemakers and need surgery, what are the issues there?
The big concern during surgery is electromagnetic interference, or EMI, especially from electrocautery units the ESU or booby surgeons use to cut and stop bleeding.
Those electrical surgical tools.
Yeah. They generate high-frequency electrical signals that the pacemaker might misinterpret as the heart's own activity.
And that could cause problems, like the pacemaker stopping when it shouldn't.
Or pacing when it shouldn't. It can get confused. So to avoid this, they often temporarily reprogram the pacemaker during surgery.
How do they reprogram it?
They usually put it into an asynchronous mode, like VOO or DOO. This means the pacemaker fires at a fixed rate, completely ignoring any signals it might sense, whether from the heart or from interference. It just paces steadily.
So it ignores the boovie noise. Makes sense. Then they switch it back after surgery.
Exactly. Once the risk of EMI is gone, they put it back to its normal settings.
But I remember reading about something called the R-on-T phenomenon. Is that a risk with this asynchronous pacing?
Yes, it is. R-on-T happens if the pacemaker delivers a pacing spike, the R wave, right on top of the T wave of the patient's own heartbeat. The T wave is an electrically vulnerable time for the heart muscle.
And pacing during that vulnerable time is bad.
It can potentially trigger a dangerous arrhythmia like ventricular fibrillation. It's like pushing someone on a swing at exactly the wrong moment can destabilize everything.
Yikes. So how do they manage that risk if the pacemaker is just firing away asynchronously?
Well, one key is making sure the asynchronous pacing rate is set appropriately. But if the patient's own heart rate tries to speed up beyond the pacemaker rate, or if they have premature beats, PVCs or PACs, you could get that R on T timing.
Could they just turn the pacemaker off during surgery?
Generally, no. That's usually too risky. If the patient depends on the pacemaker because their own heart rhythm is too slow or unreliable, turning it off could be catastrophic.
Right, okay. So turning it off is out. What about things like anesthesia drugs? Could changing those help with the interference?
Not really for the interference itself. Drugs like lidocaine might suppress extra beats, but they don't stop the boovie noise confusing the pacemaker. And changing volatile anesthetics, like switching isoflurane for desflurane, won't stop EMI either. In fact, high doses of desflurane might even speed up the patient's own heart rate, which could increase the R on T risk if the pacemaker is in asynchronous mode.
So anesthesia changes aren't the answer? But wasn't esmolol mentioned?
Yes. Esmolol is key here. It's a short-acting beta blocker. They can use it to deliberately slow the patient's own heart rate down.
Slow it down below the pacemaker's fixed rate.
Exactly. If the patient's intrinsic rate is slower than the asynchronous pacing rate, the pacemaker will reliably capture and control the rhythm every time. This minimizes the chance of a spontaneous beat occurring and getting hit by a poorly timed pacing spike, reducing the R on T risk.
Ah, clever. Slow the natural heart rate so the pacemaker is always in charge. Okay, let's switch to some specific drug classes. Phosphodiesterase type 3 inhibitors, PDE3 inhibitors.
Right. Drugs like milrinone and amrinone is also called inamrinone.
And how do they work?
They block the PDE3 enzyme. Blocking this enzyme increases levels of something called cyclic AMP or CANT-MP inside heart muscle cells and also the smooth muscle cells in blood vessel walls.
Okay, more CAMP. What does that do?
In the heart muscle, more CAMP means stronger contractions, a positive inotropic effect. Helps the heart pump better.
Good for heart failure, maybe.
Potentially, yes. And in the smooth muscle of blood vessels, more CANT-MP causes relaxation or vasodilation. Both arteries and veins relax.
So it makes the heart pump stronger and makes it easier for the heart to pump by lowering resistance.
You got it. Reduces both afterload and preload. They're sometimes called inodilators because they have both effects.
And I recall there was a significant side effect difference between the two you mentioned. Amrinone versus milrinone.
Yes, a really important one. Amrinone, especially with longer use, has a much higher risk of causing thrombocytopenia, a big drop in platelet count.
Low platelets. Risk of bleeding.
Exactly. Milrinone has a significantly lower risk of causing this. That's a major reason why milrinone is generally preferred over amrinone these days.
Definitely important to know. Okay, shifting from specific drugs to a whole body response. Systemic inflammatory response syndrome, or SIRS. What is that?
SIRS is basically the body mounting a massive widespread inflammatory reaction to some kind of major insult or stress.
Like what kind of insult?
Could be lots of things. Severe infection, major trauma, burns, pancreatitis, and relevant to our discussion, major surgery, especially procedures involving cardiopulmonary bypass like heart surgery. It's the body's fire alarm going off everywhere.
So it's a general response, not tied to one specific cause. How is it diagnosed?
It's based on clinical signs. You need 2 or more of the following 4 criteria.
Okay, what are they?
1, abnormal temperature either high, like over 38 Celsius, or low, under 36 Celsius. 2, fast heart rate over 90 beats per minute.
Temp and heart rate, got it.
3, fast breathing rate over 20 breaths per minute or a low CO2 level in the blood under 32 mm Hg, which indicates hyperventilation. And 4, abnormal white blood cell count either very high, over 12,000, or very low, under 4,000, or having more than 10% immature white cells, called bands.
So temp, heart rate, breathing rate, or CO2, and white cell count. 2 out of 4 means SIRS.
Correct.
And how does the term sepsis fit in? Is it the same thing?
Close, but sepsis is more specific. Sepsis is defined as SIRS, that is happening because of a documented or strongly suspected infection.
Ah, so SIRS is the inflammatory state and sepsis is SIRS caused by infection.
Precisely.
Okay. Now let's talk about monitoring what's going on inside the heart and vessels. Pulmonary artery catheters, or PA catheters. How do they get those in place?
They're usually inserted through a large central vein, often the internal jugular vein in the neck, typically the right side.
Okay, the neck vein, and then threaded inwards.
Exactly. They carefully advance the catheter through the veins into the right atrium, then the right ventricle, and finally out into the pulmonary artery.
It sounds like quite a journey. Are there typical distances they expect to advance the catheter to reach those different spots?
Yes, there are average depths, though it varies a bit with patient size. From the right internal jugular, for example,
Yeah.
it's roughly 15 to 20 centimeters to reach the right atrium, maybe 25 to 30 centimeters to get into the right ventricle, then about 35 to 40 centimeters to reach the pulmonary artery itself, and finally, around 40 to 45 centimeters to get it into the wedge position.
The wedge position, what's that?
That's when the tick is gently wedged into a smaller branch of the pulmonary artery. The pressure measured there indirectly reflects the pressure back in the left atrium. It's a key measurement.
So, like navigating an internal river system with known distances. What if they use a different starting point, like a vein in the arm or the leg?
The distances change significantly. From the left internal or external jugular, you'd add maybe 5-10 centimeters. From the femoral vein in the groin, it's much longer, maybe add 40 or 50 centimeters to those numbers. And from an arm vein, even further.
Right, depends on the starting point. So once the catheter's in the pulmonary artery, what kind of information does it give? I hear about SvO2 a lot, mixed venous oxygen saturation.
Yes, SvO2 is a really important value you get from blood drawn from the tip of the PA catheter. It measures the oxygen saturation of the blood returning to the right side of the heart after it's circulated through the whole body.
So it tells you how much oxygen is left over after the tissues have taken what they need.
Exactly. It reflects the overall balance between oxygen delivery, how much oxygen is being supplied by the heart and lungs, and oxygen consumption, how much the body's tissues are using.
So a low SvO2 might mean what? Delivery is poor or consumption is really high?
Could be either or both. That's why it's such a good global indicator of how well the whole cardiorespiratory system is meeting the body's needs. It integrates cardiac output, hemoglobin levels, arterial oxygen saturation, and tissue oxygen demand.
It sounds like it's related to the Fick principle.
Absolutely. The Fick principle relates oxygen consumption to cardiac output and the difference between arterial and venous oxygen content. SvO2 is essentially looking at that venous side of the equation. A falling SvO2 is often an early warning sign that something's wrong. Maybe the heart isn't pumping enough, or the patient is bleeding, or they have a fever increasing oxygen demand.
Okay, that makes sense. Now, I saw an example mentioning the drug Levolol and its effect on SvO2. How does that work?
Right. Labetalol is a beta blocker, among other things. Beta blockers can decrease heart rate and contractility, which can reduce cardiac output, the amount of blood pumped per minute.
Okay.
If cardiac output goes down, less oxygenated blood is delivered to the tissues per minute. Even if the tissues extract the same amount of oxygen from each bit of blood passing by, the overall return blood, the mixed venous blood, will have less oxygen left in it because the total flow was lower.
So lower cardiac output from labetalol could lead to a lower SvO2, even if tissue oxygen use hasn't changed.
Precisely. It highlights that you can't just look at the SvO2 number in isolation. You always have to interpret it in the context of everything else. Other vital signs, what drugs the patient is on, their clinical condition.
Got it. Context is key. Now let's clarify some basic cardiac terms. We throw words around like inotropy, chronotropy.
Yeah.
Can you quickly define those?
Sure. These describe different aspects of heart function.
Okay. Inotropy.
Inotropy is contractility, the force or strength of the heart muscle's contraction.
Chronotropy.
That's heart rate, how fast the heart is beating.
Dromotropy.
Dromotropy refers to the conduction speed of the electrical signal through the heart's pathways, like the AV node.
Bathmotropy. Never heard that one.
Less common, yeah. Bathmotropy is excitability, how easily the heart muscle responds to a stimulus.
And lusitropy.
Lusitropy is about relaxation, how well the heart muscle relaxes and refills during diastole. It's just as important as contracting properly.
Lusitropy for relaxation.
Yeah.
Is that affected by anything specific?
Yeah, actually, lusitropy tends to decrease with age. The heart muscle doesn't relax quite as efficiently as we get older, which can contribute to problems with diastolic filling.
Interesting. Okay, let's move to the lung circulation again. Pulmonary artery hypertension, PAH. What's the definition and how is it treated?
PAH is high blood pressure, specifically in the pulmonary arteries, the ones going from the right heart to the lungs. The definition is usually a mean pulmonary artery pressure of 20 millimeters of mercury or higher when the person is at rest.
And that's bad because it makes the right side of the heart work much harder.
Exactly. It can lead to right heart failure over time, so treatment aims to lower that pressure and support the right ventricle.
What kind of treatments work?
Several options. Continuous IV drugs like apoprostenol or treprostinol, these are Prostacyclin analogs are potent vasodilators. They relax both pulmonary and systemic vessels.
But relaxing systemic vessels, too, could cause low blood pressure, right?
Yes, systemic hypotension is often the limiting side effect. That's why inhaled versions of these drugs, like Elaprost, were developed to target the lungs more directly and minimize systemic effects.
Smart, Wales.
Oxygen therapy is important because low oxygen itself can worsen pulmonary vasoconstriction. Then there's inhaled nitric oxide, NO.
Nitric oxide, like the gas.
Yeah. When inhaled, it's a very selective pulmonary vasodilator. It works great in the lungs, but gets broken down so quickly in the blood, it barely has any systemic effect. Usually used in concentrations of 20-40 parts per million.
Okay. Any other drugs?
Milrinone, the PDE3 inhibitor we talked about, can also help by reducing pulmonary vascular resistance and giving the right ventricle a bit of an inotropic boost. It can be given IV or sometimes inhaled too.
So, several ways to try and relax those pulmonary arteries. What about in really severe right heart failure from PAH? I thought I saw something about using drugs like norepinephrine. Wouldn't that make pressures worse?
It seems counterintuitive, right? Norepinephrine and epinephrine can increase pulmonary artery pressure. But if the right ventricle is failing so badly that the patient's overall blood pressure is crashing...
You need to support the whole system.
Exactly. In that critical situation, the potent effect of norepinephrine or epinephrine in boosting the failing right ventricle's contractility and maintaining systemic blood pressure might be necessary for survival, even if it temporarily raises PA pressures a bit. It's a tough call, reserved for very sick patients.
A real balancing act. What about anesthetic gases themselves? Do they affect pulmonary pressure?
Yes. Generally, the common inhaled volatile anesthetics, like sevoflurane, isoflurane, tend to decrease pulmonary vascular resistance, which can be helpful.
So they relax the vessels a bit.
Yeah. But interestingly, nitrous oxide, the anesthetic gas, not the therapeutic inhaled NO, can sometimes increase pulmonary vascular resistance, so it's often avoided in patients with significant PAH.
Good distinction. Therapeutic NO, good. Anesthetic nitrous oxide, maybe not so good for PAH. Now, we've talked about pulmonary vascular resistance, PVR. What makes it go up or down besides drugs?
Lung volume is a huge factor. PVR is actually lowest at functional residual capacity, FRC.
FRC. That's the amount of air left after a normal relaxed exhale.
Right. Think of it as the lung's neutral resting volume. That's when the pulmonary blood vessels are under the least physical stress.
So what happens if you breathe in really deep, increasing lung volume way above FRC?
As the lungs inflate more, the tiny air sacs, the alveoli stretch, and they actually compress the tiny capillaries running their walls, squeezes them.
Like stepping on a hose.
Kind of, yeah. That compression increases resistance, so PVR goes up at high lung volumes.
Okay. And what if you force air out going below FRC?
When the lung volume gets very low, the larger blood vessels, the ones running between the alveoli, can get kinked or squashed as the lung tissue around them sort of collapses down. That also increases resistance.
So PVR is highest at very high and very low lung volumes and lowest in the middle at FRC.
Exactly. It's a U-shaped curve.
What about atelectasis when part of the lung collapses?
In atelectatic areas, there's no ventilation, so oxygen is low. This triggers that hypoxic pulmonary vasoconstriction, HPV response we discussed earlier. The vessels in that collapsed area constrict, which increases PVR locally, trying to divert blood away.
Okay, so avoiding extremes of lung volume and preventing atelectasis helps keep PVR low.
Let's switch to a specific heart muscle disease. Hypertrophic cardiomyopathy, HCM. What's the main issue there?
HCM is usually a genetic condition where the heart muscle, particularly the left ventricle, gets abnormally thick hypertrophied.
Thick muscle. Sounds strong. It can be, but the thickening is often uneven, especially affecting the septum, the wall between the ventricles. And this thickening can actually obstruct the path blood takes as it tries to leave the left ventricle. We call that left ventricular outflow tract, or LVOT, obstruction.
So the thick muscle creates a bottleneck for blood leaving the heart. Does the heart try to compensate?
It does, often by getting even thicker and stronger to try and push past the obstruction. But paradoxically, this extra hypertrophy can sometimes make the obstruction even worse by narrowing the outflow path further.
So what kinds of things make that LVOT obstruction worse in someone with HCM?
Several things. Anything that makes the heart contract more forcefully, like adrenaline, stress, or beta agonist drugs, epinephrine, dobutamine. can worsen it.
Stronger squeeze pushes the thick muscle into the outflow path more.
Exactly. Also, anything that decreases the amount of blood in the ventricle before it contracts low preload, like dehydration, drugs that dilate veins, nitroglycerin, really fast heart rates that cut filling time, or even positive pressure ventilation sometimes. Less volume in the ventricle makes the chamber smaller, allowing the walls to bulge in more easily and obstruct outflow.
Less filling makes obstruction worse. Okay. Anything else?
Yeah, decreasing the resistance the heart pumps against lowering afterload can also paradoxically worsen the obstruction.
That's really counterintuitive.
Yeah.
Why does lower afterload worsen obstruction?
It's complex, but essentially when it's easier for blood to leave the ventricle, lower afterload, the ventricle empties more quickly and completely. This rapid ejection can sort of suck the thickened septum towards the other wall, the mitral valve leaflet earlier in the beat, increasing the obstruction.
Wow. Okay, so for managing HCM during surgery, what are the goals? Avoid those things.
Pretty much. You want to keep the heart relatively full, maintain preload, maintain afterload, don't let blood pressure drop too much, and keep the heart rate controlled, not too fast. And crucially, avoid things that drastically increase contractility.
So if an HCM patient gets hypotensive during surgery, what's the fix? Not epinephrine.
Definitely not epinephrine or similar drugs if you can avoid it. The mainstays are giving fluids to increase preload and using a pure alpha agonist vasoconstrictor like phenylephrine to increase afterload.
Fluids and phenylephrine. What about heart rate?
Beta blockers like esmolol are often very helpful. They slow the heart rate, which improves filling, and they also reduce contractility, both of which help reduce the outflow obstruction. Sometimes narcotics can be good too if pain is causing a stress response releasing adrenaline.
So beta blockers good, fluids good, phenylephrine good. Then absolutely avoid.
Avoid beta-adrenergic agonists like ephedrine, dopamine, dobutamine, isoproterenol, epinephrine. They increase contractility and/or heart rate and will likely worsen the LVOT obstruction.
Critical point. Okay, moving to a broader risk factor. Congestive heart failure, CHF. How big a deal is that for patients having non-cardiac surgery?
It's a major risk factor, consistently ranks among the top predictors of serious cardiac complications after major elective non-cardiac surgery.
A major one. Are there other things that cluster with it in terms of high risk?
Yes. Other major risk factors often considered alongside CHF include known coronary artery disease like a past heart attack or angina, a history of stroke or TIA, insulin-dependent diabetes, and significant kidney disease, often flagged by high creatinine levels.
So CHF puts you in a high-risk group, especially with those other conditions. What's the most important thing for managing a CHF patient scheduled for elective surgery?
The absolute key is that their CHF needs to be optimally managed before the surgery. They should be as stable and symptom-free as possible on their medications.
So if they're still short of breath or have swollen ankles?
Then elective surgery should probably be postponed or even canceled until their heart failure is better controlled. Pushing ahead significantly increases the risk.
Makes total sense. Get the heart in the best shape possible first. Now, let's look at a specific valve problem. Mitral stenosis, narrowed mitral valve. What guides management there?
Mitral stenosis obstructs flow from the left atrium to the left ventricle. Symptoms usually start when the valve area is cut by about half or more. Management hinges on understanding the hemodynamics.
Okay, what are the key goals?
Number 1, prevent tachycardia. Fast heart rate is really bad. Number 2, avoid big increases in central blood volume. Number 3, prevent sudden drops in systemic vascular resistance, blood pressure. And number 4, avoid hypoxia and hypercarbia, low oxygen by CO2.
Why is tachycardia so bad in mitral stenosis?
Because the time the heart spends relaxing and filling, diastole, is when blood has to squeeze through that narrow mitral valve.
Yeah.
A faster heart rate means much less diastolic time, so the left ventricle doesn't fill properly. Cardiac output plummets.
Not enough filling time. What about avoiding volume overload?
The left atrium is already struggling to push blood through the narrow valve. If you overload the system with too much fluid, that pressure backs up into the atrium and then into the lungs, causing pulmonary congestion. Can also trigger atrial fibrillation.
And avoiding low blood pressure.
A sudden drop in systemic pressure can trigger a reflex tachycardia, which, as we just said, is really bad for filling.
And avoiding low O2 at high CO2.
Both hypoxia and hypercarbia can worsen pulmonary hypertension, which is often present because of the blood backing up from the left atrium. That puts more strain on the right ventricle.
So slowish heart rate, careful fluid balance, stable blood pressure, good oxygenation. Are there specific anesthetic drugs to watch out for.
Yes, drugs known to cause tachycardia should be used very cautiously, if at all. Things like ketamine, the muscle relaxant pancuronium, and rapidly increasing the concentration of deslorane gas.
Okay, avoid those speed-up drugs. What about pain meds?
Opioids like fentanyl, sufentanil, or remifentanil are generally good choices because they provide pain relief without usually increasing heart rate significantly.
Good options. Is nitrous oxide okay?
Usually, yes, but in very severe mitral stenosis with really high pulmonary pressures already, some might avoid it just because it can occasionally increase pulmonary vascular resistance slightly.
Got it. Careful drug choices are key. Let's switch to something very practical. Drug calculations. I saw an example for dopamine. Can you run through that?
Sure. Let's say you want a dopamine drip at 1,600 micrograms per milliliter. A standard way is to add 400 milligrams of dopamine to a 250 milliliter bag of fluid like D5W.
Okay, 400 milligrams and 250 milliliters. How do we check the concentration?
Convert milligrams to micrograms. 400 milligrams times 1,000 is 400,000 micrograms. Divide by the volume. 400,000 milligrams divided by 250 milliliters equals 1,600,000 micrograms. So that concentration is correct.
Right. Now, how do you figure out the infusion rate, say, for a dose of 5 micrograms per kilogram per minute for a 70-kilogram person?
First, calculate the total dose per minute. 5 millihilogrammin times 70 kilograms equals 350 milligrams per minute.
350 milliamin.
Next, figure out the dose per hour. 350 milligrams times 60 minutes hour equals 21,000 micrograms per hour.
21,000 milli-GHR.
Finally, divide the hourly dose by the concentration to get the rate in a hour. 21,000 milli-CHR divided by 1,600 milli-CHR, that comes out to about 13.125 millihour.
So you'd set the pump to around 13 milliliters per hour.
Exactly. You'd round it clinically, maybe 13 or 13.1 millihour.
Thanks. That clarifies the steps.
Yeah.
Now let's revisit heart rate, but summarize its importance across different valve problems. We touched on stenosis.
Right. For stenotic lesions, narrowed valves like mitral stenosis or aortic stenosis, slower heart rates are generally better. Gives more time for filling mitral or emptying aortic.
And tachycardia is especially bad in aortic stenosis.
Yes, very bad. Reduces ejection time and reduces coronary artery filling time, which happens during diastole, potentially causing severe ischemia in that thick ventricle.
Okay, slow for stenosis. What about leaky valves insufficiency or regurgitation?
For aortic insufficiency, a slightly faster heart rate can actually be beneficial. It shortens diastole, which means less time for blood to leak back into the left ventricle.
Less time for backflow. Makes sense.
Yeah.
Anything else for aortic insufficiency?
Lowering systemic vascular resistance, afterload, also helps promote forward flow out the aorta rather than backward flow. But you don't want it too low, or you compromise coronary perfusion.
Right. Faster rate, lower SVR for aortic insufficiency. What about hypertrophic cardiomyopathy again?
HCM with outflow obstruction generally does better with slower heart rates for better filling and less obstruction, and usually benefits from higher systemic vascular resistance.
Slower rate, higher SVR for HCM, and cardiac tamponade, fluid squeezing the heart.
In tamponade, the heart can't fill properly, so stroke volume, amount pumped per beat, is reduced and relatively fixed. Cardiac output then becomes highly dependent on heart rate. They often need a faster rate just to maintain output.
So, faster rate needed in tamponade. It really depends on the specific problem.
Absolutely. Heart rate management is critical and tailored to the lesion.
Okay, let's talk about a scary rhythm. Torsades de Pointes. What is it?
Torsades de Pointes means twisting of the points. It's a specific type of polymorphic ventricular tachycardia where the QRS complexes on the ECG look like they're twisting around the baseline.
Looks distinctive. What causes it?
It's often associated with a prolonged QT interval on the ECG. Causes include certain drugs, some antiarrhythmics like quinidine, some antipsychotics like droperidol, others too. Also, electrolyte problems, especially low potassium, hypokalemia, and low magnesium, hypomagnesemia, and sometimes acute heart attacks.
So long QT, drugs, low potassium, low magnesium are key triggers. If someone develops torsades and had a long QT, what's the first line treatment?
Correct the electrolytes, especially potassium and magnesium. Magnesium sulfate 5E is often given immediately, even if the level isn't confirmed low, as it's very effective.
Magnesium first.
Anything else?
Overdrive pacing the heart faster than its own rate can suppress torsades associated with slow heart rates or pauses. Isoproterenol used to be used sometimes to speed up the heart and shorten the QT,
Yeah.
but less common now. So electrolytes, magnesium, maybe pacing. What if torsades happens, but the QT interval isn't prolonged?
If the QT is normal, the cause might be different, perhaps more like typical ventricular tachycardia. In that case, standard VT treatments and antiarrhythmics might be considered, though magnesium might still be tried.
And if the patient becomes unstable, regardless of QT. Low blood pressure, unresponsive.
Immediate unsynchronized cardioversion defibrillation, shock them out of it.
Defibrillation for unstable torsades. Got it.
Nah.
Now, those electrolytes, potassium, magnesium, calcium, you said they can cause ECG changes even without a full arrhythmia.
Yes, absolutely. The ECG is a window into the heart's electrical activity, and electrolyte levels directly impact that.
What does high potassium hyperkalemia look like on the ECG?
The classic early sign is tall, peaked T waves, like sharp tense. As it gets worse, the PR interval gets longer, the P waves flatten and disappear, and the QRS complex widens. Yeah, and eventually, in severe hyperkalemia, the widened QRS can merge with the T wave, creating a sine wave pattern. That's very dangerous, often precedes VFib or a systole.
Peaked T waves to sine waves. Scary progression. What about low potassium hypokalemia?
Hypokalemia often causes T-wave flattening or even inversion. You might see prominent U-waves, those are little bumps after the T-wave. ST depression can occur. And like hyperkalemia, severe hypokalemia can also prolong the PR interval and widen the QRS, and definitely increases arrhythmia risk.
T-wave changes and U-waves for low potassium. What about calcium?
Calcium mainly affects the QT interval. Low calcium, hypocalcemia, prolongs the QT interval. High calcium, hypercalcemia, shortens the QT interval.
Hypolong, hypershort for calcium and QT. Does sodium do anything characteristic to the ECG?
Not really. Sodium imbalances, high or low, don't typically cause specific recognizable changes in the ECG waveforms themselves. The effects are more indirect, related to fluid balance or overall stability.
So focus on potassium and calcium for direct ECG waveform changes.
Okay, last big topic. Antiplatelet medications. Why is knowing their duration of action so important, especially before surgery?
Because these drugs stop platelets from clumping together, which is great for preventing heart attacks and strokes, but bad if you need those platelets to stop bleeding during surgery.
So you need to stop them before surgery, but not too early, not too late.
Exactly. You need to know how long the antiplatelet effect lasts for each drug to balance the bleeding risk during surgery against the clotting risk if you stop the drug too soon.
What about common NSAIDs like ibuprofen? How long do they affect platelets?
NSAIDs, like ibuprofen, inhibit an enzyme called cyclooxygenase, or COX, but they do it reversibly, so the effect only lasts as long as the drug is in the system. Once it's gone, newly made platelets work fine. The effect is usually gone within a day or so after stopping.
Reversible short-acting. What about aspirin?
Aspirin also inhibits COX, but it does it irreversibly. It permanently disables the enzyme in any platelet it touches.
Permanently. For how long? For the entire life of that platelet, which is about 7 to 10 days. So even after you stop taking aspirin, you have to wait for your body to make enough new, unaffected platelets before clotting returns fully to normal. That's why it's often stopped a week before surgery.
Irreversible, lasts 7-10 days. Big difference. What about prescription drugs like clopidogrel, Plavix?
Clopidogrel, Plavix, and an older drug, ticlopidine, Ticlid, are thinopyridines. They also irreversibly block a key receptor, P2Y12, on platelets needed for aggregation.
Also irreversible. How long do their effects last?
Ticlopidine's effect is quite long, maybe 14 to 21 days. Clopidogrel's effect is typically around 5 to 7 days, so again, needing to be stopped several days before surgery. There are newer drugs like ticagrelor, Brilinta, which are reversible P2Y12 inhibitors, and their effect wears off faster, maybe in 3 to 5 days.
So NSAIDs reversible 1 day, aspirin irreversible 7-10 days, clopidogrel irreversible 5 to 7 days,
Yeah.
ticagrelor reversible 3 to 5 days, roughly.
That's a good summary, yeah. Knowing those durations is absolutely critical for safely managing patients on these drugs who need procedures.
Wow. We have covered a massive amount of ground today. Robotic surgery, one-lung ventilation, transplants, WPW, pacemakers, PDE3 inhibitors, SIRS, PA catheters, SVO2, cardiac terms, PAH, PVR, HCM, CHF risks, mitral stenosis, dopamine calcs, heart rate nuances, torsades, electrolytes, antiplatelets. My head is spinning a little.
It really highlights how interconnected everything is in the cardiovascular system, doesn't it? And how understanding the physiology is fundamental to all these interventions and conditions.
Absolutely. You see how one thing like heart rate or lung volume or electrolyte level can have ripple effects throughout the whole system.
And how seemingly small details, like knowing which drug inhibits HPV or which antiplatelet lasts how long, can make a huge difference in patient care.
Hopefully for everyone listening, this deep dive has connected some dots, maybe provided a few aha moments, and given a clearer picture of these complex topics.
Which leads to maybe a final thought to ponder, just reflecting on that interplay. How changes in heart rate, blood pressure, preload, afterload, oxygenation, contractility, all influenced by diseases and drugs, constantly interact. Thinking about how managing one factor inevitably affects others is, I think, central to understanding cardiovascular medicine.
That's a great point. It's not just isolated facts, but a dynamic system. And if this discussion has sparked more questions for you, we definitely encourage you to keep exploring. There's always more to learn in this field. Thanks for joining us on The Deep Dive.